getting normal saline. And I want to go over a study that's going to be done in our emergency department. So no one knows who this is. I didn't know who this is. This is the inventor of normal saline. He's got a pretty epic mustache, and the reason the reason it's called normal saline is because saline is in in vitro sample, it was isotonic to plasma. So in vivo, that has nothing to do with the way that it operates. So he called it normal saline, and it's unclear whether saline was ever meant to be used for medical purposes as a medication that we give. But for some reason, it's kept the name normal saline, even though we're going to go over it's far from normal. So Patrice, do you know what the components of normal saline are? And do you know what concentration they're in? 154 both, yes. And do you know what's in lactated ringers? Okay, and what's physiologic chloride? Exactly. So normal saline does not match the components of plasma as well as lactated ringers does. And you can see the components right here. So I've highlighted the normal saline, and Patrice was right on the money, 154 of each component. And then lactated ringers matches our physiologic plasma much more accurately, although it's not exact. And it also contains lactate to buffer the solution. And the reason we think that is more physiologic is because when you give someone a bolus of normal saline, you're giving them a load of chloride. And chloride acts as a strong ion. And what that does is it gives a metabolic acidosis. So it promotes the loss of bicarbonate and gives a metabolic acidosis. Furthermore, there have been studies in healthy volunteers that have shown decreased renal perfusion, and that's postulated to be because of renal artery vasoconstriction. So we think that we know that it causes metabolic acidosis. It causes decreased perfusion to the kidneys, and a lot of the literature that's borne out the harms of normal saline have been from the operating room literature. And I'm not going to go over that because it's not really relevant to us. But basically, we started thinking that normal saline might be harmful when we saw that intraoperative patients given normal saline had increased mortality from those given more balanced crystalloids. So acidosis, we know, can impair our immune response, cause inflammation, and it can also impair coagulation factors. So alternatively, balanced crystalloids are not shown to do that. There is no hyperchloremia with balanced crystalloids. It does not cause acidosis, and that's in healthy volunteers. So that's a long slide, and and there's a lot of physiology, a lot about the kidney. That the kidney is very, very complicated. I tried to maybe get a slide where we're looking at the loop and everything like that, but it's incredibly complicated. But short form, too much chloride is bad. So hyperchloremia might impact mortality, and it might give an AKI, and that's what we're going to go over in literature here in this talk. So. Tiffy, can you interpret this ECG? That's right on the money. What's your differential for peak T waves? That's a great answer. Yeah. So. If it comes up on the site, you're gonna hammer it home. So would you let's say this was a very sick patient in renal failure with hyperkalemia that needed fluids. Do you have a fluid choice that you would give? Of course, yes. Aside from your calcium and your shifting. So it's 4. So that's exactly right. So hyperkalemia, although it comes up as an exclusion criteria in some of the studies, um, hyperkalemia, lactated ringers is not shown to cause hyperkalemia. And I wanted to go over some of the myths of lactated ringers. So it doesn't cause hyperkalemia, has never been proven. And in fact, again, from the OR literature, they've shown that patients receiving normal, like renal transplant patients receiving normal saline are actually more likely to require therapy for hyperkalemia than those given lactated ringers. And that's thought to be because of the acidosis that it stimulates in a shift outside of the cells. So lactated ringers is safe in hyperkalemia. And how about it raising the lactates because it has that buffered lactate? And the answer to that is that both types of fluids, both normal saline and lactated ringers, can increase the lactate. So just some myths there that maybe some of the junior people in the room might not have heard before. So that's all theoretical and physiologic, but what about getting practical right now with our discussion? When we have these patients that I might have presented in the stems for the PUL EVs, what are we going to do with those patients? What type of fluids should they be getting? And before we talk about that, I just want to frame this discussion, okay? I want to talk about what we're doing here at LHSC. And this data is from April 2017 to March 2018. And that's Emerge, UH, and Victoria. And so we are, although the PUL EV said that we're 50% giving patients 50-50, in reality, we're prescribing, like in this about 5 times as much normal saline in 1 liter bags than lactated ringers. And that's not counting our 500 cc bags. So we are giving much more normal saline, and the price difference is minimal. So $1.66 versus $1.30. If you turned just some quick math, if you turned every 1 liter bag of normal saline into lactated ringers for that year that I've presented, that's about $6,391. So I'm not obviously privy to the hospital budget, but from what I understand, that's a very low number when we're dealing with millions. To completely switch over for every patient would not be at big cost. Dr. Martin, Dr. Claudia Martin with ICU helped with these rounds, and we sat down before to go over some of the trial that he's getting into that I'll present later. And he felt like from the data, looking at the data of the whole hospital, about 1/3 of patients are getting ringers. So on the wards, they are giving 1/3 ringers, 2/3 normal saline. So let's present a case here. So a 40-year-old female presents with 2 days of feeling generally unwell. She's been in bed, unable to keep with any oral intake, high fevers and myalgias, vital signs as advertised, history of IV drug use. I don't think Marge Simpson did IV drugs, but whatever. Let's see. What can you describe? Let's say this patient was brought into the cell. Can you describe your initial approach to management in this patient?
Okay, so this patient, just based on the vitals alone, is unstable and needs a more acute care area. Appears to be in septic shock with a vital septic history. So get 2 large 4 IVs, IVO monitors, pull up some fluids, get septic labs off with blood cultures, and start with initial doses at 4.5 grams. As you're moving through your airway assessments, and how is the response to that initial treatment, and then how we go with that.
Sure, absolutely. So yeah, you're going to do your septic labs, you're going to get blood cultures, you're going to give antibiotics, you're going to give fluids. And as we know, this isn't an exciting lecture about sepsis. This is more of a boring lecture about fluids. What type of fluids are you going to give?
I think at a reflex, like you said, I typically just go to normal saline just because I'm not aware of any other systems. One is better than the other in the department. And I think right now it's just volume, so I'd probably go with.
Great. Okay. So that's good. That's good. Okay. So and normal saline, it's accessible. Usually it's already hung up before you even ask about it. Sometimes even before you think about it, it's hung up. So I think that's a very reasonable answer. But why don't we talk about that, and why don't we go into what the literature is saying for these patients? So after all of the OR literature that I will not be presenting, there started to become some trials in critical care patients that showed a difference between the two balanced crystalloids. And the first systematic review that I could find that kind of postulated that there's a difference was this systematic review in the Annals of Internal Medicine in 2014, done in Hamilton. So they did a systematic review, and they actually looked at every type of fluid. So this is a very heterogeneous mixture of studies. They looked at colloids, they looked at normal saline, they looked at balanced crystalloids, they looked at starches, and they compared all of them to each other. And knowing that this is a very heterogeneous mix, it would be very hard to draw any conclusions based off of this. But their 14 studies, about 19,000 patients, looking at normal saline versus lactated ringers, they, with very low confidence, said that there is a difference in mortality among septic ICU patients getting lactated ringers or balanced crystalloid compared to normal saline. And because there was no randomized control trials that actually compared them together, they said that you can't really draw any conclusions based off of this, but based on what we talked about before, there is biological plausibility that giving a very ill septic patient that might already be acidotic might worsen outcomes. So they said that they concluded, or in their discussion, said that there might be a need to study this further. And so then shortly thereafter, they came out another in the critical care world retrospective review. They looked at 360 U.S. hospitals, and they compared outcomes after resuscitation of critically ill ICU patients with sepsis. They compared directly balanced crystalloids to normal saline. And this trial, they used something called propensity matching. So 360 emergency departments over the span of a year, that's a lot of patients. They found 6,730 patients. And what they did was they identified the ones that just got normal saline. And then they tried to use something called propensity matching, which I'm sure some people in the room know more than I do. But basically trying to match various what they think are covariates that might be, that might make them more likely to get normal saline or lactated ringers. They tried to make these patients similar, match them together, and then compare them in terms of what their outcomes are. And when they used, sorry? Oh, I thought someone said something. Okay, so when they used this propensity matching and compared the patients directly, they found that there was a mortality difference. So 19.6% mortality in the lactated ringers group and 22.8% in the normal saline group. So not a big difference, but we're not talking about, we don't need a big difference, right? We're only talking about $7,000 to completely switch over for a year. So it's not like we're looking for dramatic outcomes in our change in fluids, but they found a little difference. But there were problems with this study. So the problems is that even though they used this propensity matching, there was a difference between the groups. Generally, the ones getting balanced crystalloids were younger with less comorbidities, although they were sicker, more likely to receive mechanical ventilation, more likely to be on vasopressors, and spent more days in the ICU. So we're starting to get a trial that's flawed, but we're showing a difference. So I think that there's something there. And that's just for sepsis. So not only just for sepsis, but there were trials coming out around the same time, reviews that showed that not just amongst the septic critically ill, but if you looked at every single critically ill patient and showed whether you gave them lactated ringers or normal saline, there might be a difference in mortality. And what this trial did was they looked at a very large database in the United States, 10,250 patients, and they basically showed a correlation amongst improved mortality, so less mortality, and percent of lactated ringers given. So they calculated based on a percent of the balanced crystalloids. So right now we have some trials that are in the intensive care literature, and they're retrospective reviews. And I think that after presenting this, I hope everyone on the room is on the same page that a randomized control trial would probably be appropriate given this mortality difference. And mortality difference is really one of the most important outcomes we have in medicine, if not the most important outcome. So then in 2015 comes out the split trial in JAMA. So this was a double-blind trial, double crossover, meaning that it was blinded, and center would be allocated to either balanced crystalloids or lactated ringers, and I believe they used plasma light, so not lactated ringers, plasma light or normal saline, and then they would give that fluid for 7 weeks in the ICU, and then they would cross over and give the normal saline, whatever fluid they weren't given, for another 7 weeks. They included all patients that were admitted into the ICU. Their primary outcome was they excluded patients that were getting renal replacement therapy, were already on renal replacement therapy, or palliative slash organ donation patients. And their primary outcome was AKI at 90 days, and they defined AKI as an increase in creatinine, 50%, or a persistent increase in creatinine, or end-stage renal failure requiring dialysis. And they recruited 2,278 patients. So I want to remind you, we're looking at very, very small differences here in terms of outcomes, and they found that there was no difference in baseline characteristics. 2 liters of fluid given to each treatment group. So 2 liters, I would say we very often give 2 liters of fluid to our critically ill patients in the eMERGE. So even though it's an ICU trial, I would say it's still relevant to what we do for our sick patients, and there was no difference. The secondary outcomes were also not different. However, this trial had some major weaknesses. So strengths is that similar amount of fluid between the 2 groups. We like randomized, double-blind, controlled trials, and they had a good clinical endpoint. I think that we all care about AKI, and as we should. However, greater than 90% of patients that were enrolled in this trial had already gotten a fluid before they came to the ICU, and over 50% of those patients actually had already received plasma light, their balanced crystalloid that they used in that center. There was a low incidence of AKI in general, as well as a low mortality in these patients. Mason's in ICU right now, or would you say that there's AKI in 10% of your patients, or more than 10%? So it's definitely more. So why is that? And the reason why is because 70% of these patients were actually received from an elective OR. So that, I would say, has very poor validity in terms of what we're doing in eMERGE. Furthermore, it's got poor validity to what they're doing in ICU as well. So I think that when this trial came out, even though there was no difference, I think a lot in the field were still waiting for a trial. So this is probably the most important and most recent paper I'm going to present today, but needing a high quality evidence for a difference between crystalloid fluids, the SMART trial came out. That was in New England, and that was released in March of 2018, so this year. So this was a pragmatic, so they tried to make it very practical. It was unblinded, so very important and obviously a significant weakness, and randomized trial, and they included all adults that came into their ICU. Their exclusions were hyperkalemia, which we talked about might not make so much sense based on what's in the literature right now, as well as brain injury, which is something we might talk about later. And they randomized 15,802 patients. So when we're looking for a very small difference in mortality, small difference in AKI, I much rather have a 15,000 patient trial than a 3,000 patient trial. And their primary outcome was something called MAKE30. And I think that the authors of this trial are trying to make MAKE30 the new MACE, like the new major adverse cardiac event. I think that they're making it is a composite of renal outcomes, and it's a composite of death, death from all causes, new renal replacement therapy, or persistent kidney dysfunction defined as a creatinine greater than 200% of baseline. So we'll talk a little bit about that as a composite outcome, but as we've probably gone over in Journal Club, we need to be wary of composite outcomes. It's not that they're bad, it's just that if a composite outcome shows up as significant, we want to know what is driving that change, and is it something that makes a difference for us. So their secondary outcomes were the standard kind of ICU trial outcomes: mortality at 30 and 60 days, vent-free days, vasopressor-free days. So About 16,000 patients. Median fluid administered was 1 liter. Patients obviously in the ICU got up to 7 liters in this trial. And this was a very good trial in terms of what they looked for. So they demonstrated a biochemical difference between the groups. So what has previously been shown in healthy volunteers, we know that there was more hyperchloremia and less bicarb in the normal saline group. So doing those same physiological changes, and they found a difference in MAKE30. So 15.4% in the normal saline group had MAKE30, and 14.3% of balanced crystalloid. So a number needed to treat of 94. So if we're looking at that 94 patients, we're then looking at a price difference of, let's say, 33 cents per switching over 1 liter. You're looking at something that's in the hundreds of dollars to prevent one outcome of MAKE30. And I'm really happy that Dr. Pringle's in the audience, because Dr. Pringle's an excellent skeptic when it comes to these trials. So I'm looking forward to hearing what you say about that, maybe towards the end, if there's anything to say. They also found that so there was a difference, and they found that there was a difference in mortality as well, and that was 30-day mortality, and that was in the septic population. So 29.4% in the normal saline septic patients had died, and 25.2% in the balanced crystalloids, and that was significant. So we're starting to see some of the literature that came from the OR literature is now in a randomized trial is starting to make a difference here for critically ill septic patients. So strengths, they addressed some of the strengths that the split trial did not. So it was well powered, because I don't think I said this before, but the split trial, the last trial I went over, was underpowered to detect a difference based on sample size calculations of what they think the treatment effect is. It was a high proportion of emergency department patients. So I believe about 50% of the patients brought into the ICU came from the emergency department. And also, they coordinated with either the OR or the medicine wards or the emerges that they were getting these patients from, and they gave study fluid to those patients before they got to the ICU. So that was not a confounder here in this trial. But there were some weaknesses as well. So we talked about composite outcomes. None of the subcomponents of the composite outcome were significant. The only other thing that was significant was the septic patients specifically. But in terms of the MAKE30 components, they were not. No one of those components were significant, and it was not blinded. So we obviously are looking for blinded trials when we want the highest clinical evidence. So that's where we're at right now with the literature. I think, given this literature, given this deep dive of fluids, I think that critically ill hypotensive patients requiring fluids should be given lactated ringers in the emergency department. That's the way. That's my opinion. I think that there is equipoise, and I think that there will be trials that come out in the future with regards to this. So it's not like it's at this point there will be more coming in. But if I'm in the resus bay and there is a hypotensive patient that is likely going to the ICU, I would ask for ringers before I ask for normal saline. Yes, Dr. Pringle.
Mark, there's been a lot of paper. Are you trying to tell me that 1 liter of either normal saline or lactated ringer in 15,000 patients makes mortality 1 liter?
So that's how much. That's the median fluid administered in this trial. That was 1 liter. In a perfect world, there would be a blinded randomized control trial, and you would look at every single cc of fluid that's going into that patient. There was no other differences that they identified between the patient populations in this trial. So both treatment arms were similar, and I would guess that for these critically ill patients, most of the fluids that they had gotten were before they came to the ICU, and there was obviously a big range of fluids that were given. So no, I don't think that 1 liter would make a difference in a vacuum. I think that some patients need more, some patients need less, but I think that the proportion of lactated ringers or balanced crystalloids that we're giving is important, and I think that it might make a difference in outcomes, yes. So if you give 1 liter, it depends on your practice. If you have a patient in the resus bay and you give 1 liter, and then you're calling your consulting service right away, and then they're managing the rest if the patient is persistently hypotensive, no, I don't think it would make a difference. But I think that if you continue to reassess that patient, continue to give fluids, then that fluid choice should be lactated ringers.
I think what often can happen is that people will continue whatever fluid is already running. The amount of momentum needed to change that fluid, I count it in the emergency department sometimes challenging because it's already hanging. Like, oh, maybe you really want to use ringers. And yeah, so I think that's the problem with that. Whatever part of the test is 1 liter. Like, what you test, what you think. I mean, I don't get, Mark, don't get me wrong. I think you're correct in your whole presupposition. I think that's where we're going, and it makes sense to me, but I'm not sure that the evidence over there, evidence of 1 liter difference. I mean, like I said, and then in physiological rationale, the reasoning is doing things in medicine for depth got into a lot of trouble to make big mistakes. So I mean, you present evidence that you agree is weak and not very good on that. And I just, when you talk about 7, 8 weeks or whatever in ICU, and you're trying to take 1 liter of normal saline or 1 liter of ringer lactate made a difference in mortality. That's just really hard to believe. And there was a lot of criticism of this trial.
Absolutely, and you're right. You're right. There needs to be better trials that come out, but the question is, are we there yet in terms of I think that there's a lot of different scenarios where we give fluids. It's probably one of if not the most pervasive medication that we administer in the emergency department. And I think that there's a lot of different scenarios that we're giving it in, and I'm going to go over some other scenarios right now. But for this patient, this critically ill septic patient, it is my opinion, and I'm saying my opinion because if I thought the literature was strong enough, I would say it's in the literature. We have to be doing it. That they should be getting lactated ringers. And at the end of this, I'm gonna present a paper, a study that we're going to have here in this emergency department in our whole center that will be comparing the 2 crystalloid solutions. So we'll go over that. But yeah, right now there's equipoise. Dr. Yan?
Yeah, I don't always agree with Derek, but I have to agree with Derek from this standpoint too, is that a lot of the patients in this study, as I think you said in your next slide, perhaps, had already received fluid prior to arrival to ICU.
Yeah.
So it really brings into question whether or not I'm going to change my practice of what the fluid was before the study started or an endpoint of the study based on the results of it. Does that make sense? So in terms of what I'm going to do in the ED in that golden hour for someone who's critically ill, whether that first leader or even second leader is really going to change that patient in a more important outcome is really something that I need to think about, and whether that's going to change. And the evidence as it stands right now does not support that I'm going to necessarily change my practice. I think Mason's point is well taken, that what continues on once the patient is resuscitated for into the first 24-hour period or so on is probably going to make more of a difference to the patient's outcome as opposed to the first liter or maybe even 2 liters or whatever that I'm starting to need.
And they, just to make it clear, they did coordinate with the emerges to give the same fluid that the patient was allocated to. So it's not like they did that was a significant improvement of this SMART trial over the last trial, is that if they were randomized, if the center was randomized to balanced crystalloids, the emerges were giving balanced crystalloids. So, Dr. Dreyer?
Mark, do you think this trial represented patients who were comparable to patients that we sent to the ICU? To me, looking at patients who got a median 1 liter, coming back to the issue of 1 liter, does not represent patients we sent to the ICU. I mean, our septic patients were patients who were shocked for other reasons, tend to get a lot more than 1 liter.
So-
I'm wondering if this is actually be a good comparison to what we received.
So that's an excellent point. So this was a median 1 liter that they received in the ICU. I think they could have gotten fluid in the emerge, yes. Yes. And I don't know how much fluid they got in emerge. At this point, it's hard to remember every detail of multiple trials. That would be relevant to know right now, but that was the amount that they had received in the ICU. And there, as many of you probably already know, there was a trial that came out in the same issue of New England that was in the emerge patients that were not critically ill that we're going to go over. But yeah, so definitely I would agree. I don't think that this is perfect evidence here, but I think that there are differences that they did show that are going to be important in the future to investigate. But again, that's why I'm presenting my opinion. My opinion is that if I'm in the research bay, I'll ask for lactated ringers. Biologically, as well as all of the research that's coming out, we know that it's not harmful, and we know that normal saline, there are beginning to be opinions that it could be, and certainly there's biological plausibility.
You don't want to give ringers like because of the hypotox, you don't want to give them more brain. So
that's a spoiler alert. That's a spoiler alert.
Okay.
Absolutely, though. I agree. Okay, so let's present another case here. So how about Grandpa Simpson here, who's coming in? He's got a 75-year-old guy. He's got pneumonia. He's got multiple comorbidities, and he has a clear AKI. Creatinine is increased from baseline. He's hemodynamically stable and requiring just a little sniff of oxygen in the nasal prongs. So I think that we would all agree this is a patient that should be admitted to the hospital, probably under medicine, unless they have a regular respirologist. So how about here? Mason, what are if you were going to treat the AKI with fluids, what would you give? Does it matter? So Mason is going to give ringers lactate, and we'll talk about what the evidence is for this more stable elderly patient, so with AKI. So there really hasn't been much literature that's come out about this, and really the first trial that's looked at these more stable, non-critically ill patients and tried to find a treatment effect, it came out in March of this year, and that's the SALT-ED trial. So this was single center. It was unblinded. It was in one of the same ICUs in Vanderbilt that they did the SMART trial, the last trial that I presented. And they did an unblinded multiple crossover. So they crossed over with the ICUs, so per calendar months for 16 months. And they included all patients over 18 that received at least 500 cc's of crystalloids in the emergency department. So as to Dr. Dreyer's point, a little bit more relevant to our patient population. And their primary outcome was hospital-free days before day 28. So they basically, if the patient was discharged before day 28, so they would count for 1 if they were discharged on day 27. If they were discharged on day 3, they would be 25. And then they also looked at death. So if the patient died, they did not count as hospital-free days if they died before day 28. Their secondary outcome was MAKE 30, so the composite that we talked about before. And they enrolled 13,347 patients, and they did not find a significant difference in terms of their primary outcome. So there are going to be some strengths that we're going to go over with regards to this trial, but no difference in primary outcome. And then in terms of their secondary outcome, which was their MAKE 30, as you can see on this graph, there was a significant difference. 5.6% MAKE 30 in the saline group, 4.7% in the balanced crystalloid groups. And again, similar to the last trial, none of those subcomponents were statistically significant. So we're talking right now about more stable patients, an NNT of 111 to prevent one MAKE30 event. And we really, I think that we as clinicians need to decide if we care about MAKE30, which is something that might come up. Hopefully it comes up as some discussion after. But the authors do cite a very heterogeneous treatment effect. So again, remember, with composite outcomes, we need to look at what is driving that change. And what the authors postulated was driving this change here is that those with renal dysfunction, so if they had renal dysfunction either pre-existing or at that presentation, or they already had hyperchloremia, they had the greatest to gain from lactated ringers in terms of difference in MAKE30. So as to Mason's point, this patient that was already had an AKI, had something to gain according to this unblinded trial with regards to preventing MAKE30. But I think we can all agree, if the patient is going to get a liter of fluids with us because they have an AKI and they're hemodynamically stable, probably not going to make a difference in terms of mortality and discharge to hospital. So what are the strengths of this trial? It was a good validity of the trial. So 70% of these patients were general medicine admits, 19% were general surgery, 5% cardiology. The rest were kind of all the other services. Based on my clinical practice, I didn't look at what we have here in the hospital, but that is pretty reflective of my pattern of admissions. 95% of study fluid was lactated ringers, so we can kind of bring that into our hospital because we are giving lactated ringers and not plasma light. And I also like, I like MAKE30 as an outcome. Do I think it's the most important outcome ever? No, but I think that it's important, and my gauge for that is I care about it in my patients, and I would care about it, for people that I know as well. I wouldn't want an increased creatinine to 200, to 200% of my baseline. I wouldn't want a persistently increased creatinine. I don't think that is something that I think it makes a difference, is what I'm saying. Even though it's a biochemical abnormality, I do think it makes a difference for our patients in terms of their life, particularly if they get sick again. So I do buy MAKE30 as something that we should be studying in these patients. Weaknesses of the trial, again, it's not blinded. Positive results with a composite outcome. So according to this, at least in some scenarios, balanced crystalloid is they're saying is a superior choice. So next trial that I have, I'm not going to spend too much time on this. This is just a trial. I threw it in because really, I think we're about to see a lot of very poorly designed trials. They're looking at crystalloid choice in the emergency department, and this basically just took healthy patients that were discharged, usually had a non-specific gastrointestinal issue that they're coming in with. They gave them 2 liters of fluid, blinded, might not have even been an indication for fluid, and basically showed that the fluid choice does not affect the quality of recovery. So I guess the only thing really to say about this trial is that, as Dr. Pringle was saying, in our patients that are coming in and they're going to be discharged, and you hang a bag of fluid, it probably doesn't even need to be done for some sort of, magic to make them feel better because they got fluids. Probably doesn't make a difference in terms of their recovery when they go home. And I think that's very reasonable. So no strong evidence to suggest that in a non-critically ill population, normal saline causes significant harm, but maybe we need a trial that shows that. And unfortunately, I only have like 5 or 10 minutes left, but I guess we can go the full hour. This is the trial that I was talking about with Dr. Martin, and this is coming to our emergency department. I know this is a very busy slide, so I'll just talk around it. Basically, Ottawa, Kingston, Toronto, London, and Hamilton, all of their academic centers will be involved in this multi-center trial called the Fluid Trial. And what it's going to be is a hospital-wide intervention where it's unblinded, and we will be allocated to either normal saline or balanced crystalloids, and we'll be giving that for 14 weeks. So we'll be randomized for 14 weeks. Then we'll have a 1 to 3 week washout period to switch our fluid around, and then 14 weeks of the next fluid. every single time you order, once they get started, which I think will be in December or January, every time you order a liter bolus on the EMR, it will give you a notification saying that we've been allocated to either normal saline or balanced crystalloid. And if you pick the opposite fluid, it'll ask you if you want to switch. You'll be able to override anything you want. And what they're going to look for, their primary outcome, is going to be mortality and readmission rates. And that's data that they're collecting from ISIS, the Institute for Clinical Evaluative Sciences, not obviously not. I think this is like, is this not the most unfortunately named like research thing in the whole that's ever happened? I feel very bad for the people that name that. But anyways, so there will be no data collection, but it's just going to be the mortality and the readmission rates that are reported to a big database. So when I was talking to Dr. Martin, unfortunately Dr. Martin couldn't make it because he had a conflict. But it's a very pragmatic trial. They're going to try and give everyone, they're going to try and switch over completely for those 14 weeks, switch over completely again, and just see at the general hospital level if there were any differences in outcomes. I do suspect that if there is a difference, that we as LHSC might just switch over completely and however much that costs. So no data collection required. You'll be notified on EMR. And they're going to have, over the Emerge and the wards, they're going to have fluid carts. And basically, it's going to be a study cart, and it's going to make sure that those carts are stocked with the study fluid. So in terms of the design here, this is just a pictorial of, like a kind of way to follow what's going to happen. Just in terms of some advantages over the NEJM study, there's going to be a washout period because some patients in the NEJM studies did get both study fluids. I think it was about 5% while they switched over, whereas that will be addressed here. Again, it will not be blinded, and fortunately, no data collection will be necessary because it's a big undertaking. So that's what's coming here. I think that they want us to run 50 minutes, but when should one choose saline over lactated ringers? Are there any, Mike Clemente, are there any, I know that Dr. Pringle kind of already said, but what do you think in terms of the head injury?
Yeah, I mean, the only thing I can think of is if you wanted to actually have a self-flow, so like cranial hypertension would be one that I can definitely think of off the top of my head. I'd still be probably reticent to choose, even though you presented some good data on the lack of negative outcomes in hyper-K, if I don't think that there is going to be a strong need to choose triggers, otherwise I'd probably in a hyperscaling state.
Okay, yeah. So in terms of head injury, this is so the reason that Dr. Pringle said that in the head injured patients they should not get lactated ringers is because it's actually not isotonic. Lactated ringers is slightly hypotonic. So there's this theoretical risk that if you give lactated ringers, that you're going to cause fluid influx into the brain and cause increasing pressure. So that has never been proven in terms of any outcomes. It's very, very weak, and so that will not be an exclusion for the fluid trial that they're going to be doing here. That's never been proven, but it is theoretical. Also, as you probably all know, we're going through a lot of Rosens, myself and the rest of the PGY5s. There's a lot of Rosens, so we're doing environmental this week. For what it's worth, Rosen said that in a profoundly hypothermic patient, to avoid lactated ringers because they have decreased lactate clearance. One of the new things I learned this week, and again, I don't think there's any evidence to back that up either. So, in conclusion, my opinion is that lactated ringers should be used for hypotensive patients needing volume resuscitation. I think that with regards to more stable patients, the jury's still out. I think that we're just very much in the beginning stages of trials that will be coming out that will show whether it makes any difference, although certainly there is some biological plausibility that for some patients being admitted, particularly if you're concerned for renal failure, that lactated ringers might prevent some negative outcomes. And LHSC will have a trial coming December or January that will probably impact, as we've already talked about, that will impact the way that we go in terms of what we stock here for fluids. Oh, so this was a pull EV. I'll load it. That's my last slide. Um, I think I already know what everyone's going to say based on what they've already been saying, but just another thing to vote on.
Mark, just to be clear, in the trial that we're going to be involved in, it's not blinded, correct?
Correct.
The bags are not going to be
Not blinded.
Mark, thanks for an excellent presentation. You did a really good job. I appreciate your passion for it. And I think you're probably, I think you'll be shown to probably be correct. And I think all of us need to practice the testing that you've been playing in the past 20 years. I think we soon need to start thinking of the foods we give as a kind of drug that we could a little bit more modern with the kind of thing. But I'm not sure if the evidence is totally good yet.
And I think that we'll have more coming in the pipeline. So thank you. Yeah. So sounds like some people went the other way in terms of now they're not. They were convinced before that ringers was the way to go, but now they're going to give. They're not sure. So, but that's fine though. It's it's all kind of work in progress. I'm curious if there was no difference in price, what would you give?
I think that's one of the strengths of this argument. I think that I'm really happy that there's no drug companies involved. That was the crazy thing I think that I can all remember the sepsis campaign, surviving sepsis, the crazy drugs they're trying to get us to give that were really expensive. So there is nobody trying to sell something here to us. And that's the right. That's something. You give one dose of something and that'll take care of all that in a year.
Sure.
I think part of my food choice, like normally I probably choose ringers when they're coming but in a involved behind percent. But the two things I'd say affect my choice the most are half the time the bag's already hanging, and I feel like if you take off the bag of normal saline and switch it out for a ringer's lactate, it's a bit wasteful, and I'm not sure that I'm convinced enough that I'm going to start doing that. And the other thing is when you're busy on the quick orders, there's only normal saline. And a lot of times I'm just thinking, well, so if there's lactate ringers up there, I probably would give it more.
Sure, that's an.
Oh my God. Sorry, I could that. I think for the hypocalcemia piece, AG concerned about the ringer's lactate. So there's theoretically, as I think you said, Mark, more concern about saline compared to ringer's lactate.
Thank you, everyone, for paying attention and being here. So appreciate it, and thanks to Dr. Giffen for your help with the rounds, and to Dr. Martin.